So good morning, everybody. Today I'll be talking about ischemic optic neuropathy. I would like to acknowledge Dr. Corbett for providing some of his slides to me. Now, any talk about AION cannot be complete without acknowledging the role of Dr. Sohan Here. He has spent his lifetime working on the vascular aspects of the optic nerve, starting with the initial description of the posterior ciliary artery, the central retinal artery, going on to the descriptions of the different disease processes that involve the vasculature of the eye. So a tribute to him, and he is currently an emeritus professor at the University of Iowa. He's a very close friend of Dr. Corbett. He has more than 250 publications to his name dealing with different aspects of this condition. I have no financial disclosures to make. So the goals today would be to revise the vascular anatomy of the optic nerve and to update the pathophysiology, the clinical features, and the risk factors for ischemia of the optic nerve. So I'll start off with the anatomy of the optic nerve, go on to describe the anterior ischemic optic neuropathy, the posterior ischemic optic neuropathy, and then conclude. I will not be dealing with temporal arteritis today because that's a completely different subject and would require a grand round of its own. The optic nerve can be divided into 4 sections, very important when we try to figure out what's going on with the optic nerve in AION. The smallest and perhaps the most interesting part is the intraocular, which is a few millimeters in length. The second and the longest part of the optic nerve is the intraorbital part. The third is a small intracanalicular part. And the fourth is the intracranial part. Now, what's interesting about the intraocular part is depicted in this picture over here. The axons of the retinal ganglion cells are radially directed on the retina and then make a sharp 90-degree curve as it enters the optic nerve. Now, this lends itself to different disease processes because a lot of energy is needed for an axon which makes that sharper curve. It's at this part that the axons travel from a relatively high pressure, that's the intraocular pressure part of the eye, to the relatively lower intracranial pressure surrounding the optic nerve, in the intraorbital part. Third, there is a sharp edge where the axons become myelinated. And fourth, the vascular supply also changes as it traverses this part. So histologically, the intraocular part of the optic nerve has been divided into the prelaminar part, the laminar part, which is the part that's enclosed by the sclera, the scleral opening, and the retrolaminar part, which is myelinated. The lamina cribrosa is another important structure which is visible to us when we look at the optic nerve. So this is not exactly a healthy optic nerve, but was put here to explain the different structures. So the optic nerve is oval, it's usually vertically oval, has a central cup which has a structure which is called the lamina cribrosa. So the lamina cribrosa, you can see a scanning electron microscopy picture of it, comprises about 200 to 300 openings. It's virtually like a sieve. It's made up of collagen and glial columns which form a tight seal around bundles of axons as they enter the optic nerve. So you have this peculiar structure which essentially separates the axons into bundles. The importance of the lamina cribrosa is it shields the retrolaminar structures from the high intraocular pressure. And as you can guess, lamina cribrosa is subject to damages of its own, and the commonest one being glaucoma. So if the intraocular pressure becomes high, this structure gets damaged, and as a result, the optic nerve axons are also damaged. It is present in all discs histopathologically, although we may not be able to visualize it in some discs which are called small coupless discs. The orbital optic nerve is like any other cranial nerve. It's separated into bundles by connective tissue septa. It is surrounded by the leptomeninges. There is a rich plexus of blood vessels called the PL network, which derives its supply from numerous sources, including the ophthalmic artery, the central retinal artery, the posterior ciliary arteries, and so on. And as it approaches the intracranial component, it also gets branches from the ACOM and the ACA as well. This part of the optic nerve is believed to be particularly resistant to ischemia because of this rich PL network. All vasculature to the eye and to the orbit is derived primarily from the ophthalmic artery. The ophthalmic artery is the first major branch of the ICA as it emerges out of the cavernous sinus. So you can see that there's a sharp bend as the blood vessel emerges from the ICA and then accompanies the optic nerve into the orbit on its lateral aspect. Before it separates out into the major branches that supply the musculature and the other soft tissue of the orbit, it gives off two important branches. The first one is the central retinal artery, which pierces the optic nerve roughly at the junction of 1/3, 2/3, and then follows it all the way through into the optic disc. The other important branch is the posterior ciliary arteries. Typically, there is about either one or two long posterior ciliary arteries. One is on the medial aspect, one is on the lateral aspect of the optic nerve. As it approaches the globe, it splits off into smaller branches and pretty much surrounds the optic nerve in a clock hour fashion to form the short posterior ciliary arteries. These are exquisitely important because this is what supplies the optic nerve, especially the laminar and the retrolaminar part, and plays a vital role in ischemic optic neuropathy. So the posterior ciliary artery supplies the disc, the choroid, and the retinal pigment epithelium. The central retinal artery, as it branches out, supplies the more superficial layers of the retina. As visualized on scanning electron microscopy, you can see the central retinal artery and the vein at the disc, and you can see the small branches that come out to supply the peripapillary regions. So the most superficial part of the optic nerve head, or the nerve fiber layer, is supplied by the branches of the central retinal artery. Now this is the most superficial part. If we go to the prelaminar part of the optic nerve head and the laminar part of the optic nerve head, they are primarily supplied by the posterior ciliary artery. Now, there is some debate over whether most of the anterior optic nerve is supplied by the posterior ciliary arteries directly or by means of the choroidal arteries. Dr. Hare believes that the choroidal arteries are what supply most of the optic nerve head, and he believes that the disc is at a watershed zone and is predisposed to ischemia when the blood supply drops down to the choroid. Whereas other investigators believe that this may not be so. The laminar part of the optic nerve head, on the other hand, is supplied more directly by the short posterior ciliary arteries, and it forms an anastomotic circle around the optic nerve called the circle of Zinn-Haller. The circle of Zinn-Haller is an anastomotic network of blood vessels. Most of the times it is not complete, but histopathologically the arrangement is such that it clinically correlates with what we see in ischemic optic neuropathy. It receives its blood supply from the posterior ciliary arteries, usually the 4 to 8 short posterior ciliary arteries, the choroidal feeder vessels, and the perineural pile network of blood vessels. It lies deep within the sclera. We cannot see it, and it surrounds the optic nerve at the neuroocular junction. The circle of Zinn-Haller has these radial small arterioles, which are paroptic arterioles, which are directly responsible for the vasculature of the optic nerve head. And this is what is believed to be responsible for ischemic optic neuropathy of the anterior variety. It is also believed that these blood vessels are autoregulated by, in response to blood pressure drops, hypoxia, carbon dioxide, and other autonomic regulators. The retrolaminar part of the optic nerve is supplied depending on what zone they are in. The orbital we had already described has a rich plexus of blood vessels in the pia mater, and it is very resistant to ischemia. The intracanalicular part of the optic nerve, which is the part in the bone, is the watershed region between the ciliary arteries and the ophthalmic vasculature versus the brain vasculature by itself. So anteriorly, it receives collateral branches from the ophthalmic artery, and posteriorly, it receives PL vessels from the superior hypophyseal arteries and sometimes directly from the internal carotid artery. The small intracranial part of the optic nerve receives its blood supply from different sources, which you can see out here, primarily from the anterior cerebral and the anterior communicating. Classification of ischemic optic neuropathy, it is done on the basis of where the lesion is. The commonest variety that we know of is anterior ischemic optic neuropathy. A much rarer variety is posterior ischemic optic neuropathy. It's also classified based on what causes the ischemic optic neuropathy. Commonest variety is non-arteritic or a vasculopathic kind of ischemia. The less common variety, but the one which is a medical emergency, is the arteritic variety, commonly from giant cell arteritis. Some authors have also talked about ischemic optic neuropathy without any obvious visual field defect, and these are variously described as pre-infarct or incipient ischemic optic neuropathy or diabetic papillopathy. So the anterior ischemic optic neuropathy is now divided into two parts, the arteritic and the non-arteritic variety. I'm not going to talk about the arteritic variety today. That's another talk altogether. We'll focus on the non-arteritic ischemic optic neuropathy. This is by far and away the commonest optic neuropathy beyond the age of 50 years. So if you see a pale optic nerve in a person above the age of 50 years, it's quite safe to call it ischemic in nature. Usually starts about the age of 40s, but between the age of 40s to about 50, I am very hesitant to call it ischemic optic neuropathy, and I always end up looking for other causes. And remember, it is 7 times more common than giant cell arteritis. The pathogenesis of non-arteritic ischemic optic neuropathy has been the subject of much controversy, and again, it's because we probably don't know enough about it. And a lot of contribution to this field comes from the work of Dr. Hare, and whenever there is no reference listed, you can safely ascribe it to Dr. Hare. It is commonly believed to be a small vessel disease. And going back to the anatomy, those radial paroptic vessels are believed to be the ones that contribute to ischemic optic neuropathy. Despite studies which have looked at the histopathology of patients with ischemic optic neuropathy, nobody has been able to exactly pinpoint either the location or the mechanism of ischemia in these cases. Fortunately for us, the eye is easily accessible, and most of the studies have been performed using different types of angiographic techniques such as fluorescein angiogram or the indocyanine green angiogram. Dr. Hare based his entire clinical study of ischemic optic neuropathy on fluorescein angiogram and supplemented it by primate models of ischemia and primate models of ocular vasculopathies. Although there is no definite evidence for location, the controversy is between primary involvement of the posterior ciliary arteries versus the distal paroptic vasculature. The fundus fluorescein angiograms suggest both. So Dr. Hare has shown that in cases of ischemic optic neuropathy, there is often hypoperfusion of the peripapillary choroidal vasculature and suggests that around the optic nerve is a watershed zone which involves the choroid and the optic nerve, and hence both are involved. Other authors have suggested that this may not be so, and it's the direct paroptic branches that are involved. Systemic factors have been implicated in ischemic optic neuropathy, and these include failure of autoregulation, vasculopathic and coagulopathic risk factors, and nocturnal hypertension. Uh, Most of the patients with ischemic optic neuropathy have other risk factors, including hypertension, chronic atherosclerosis. They are on autonomic medications, they have diabetes, they have hypercholesterolemia, and it is felt that these insults, as they build up over the course of the years, eventually lead to loss of autoregulation, and something triggers ischemia and tips it over the edge. Dr. Hare believes that the triggering factor is nocturnal hypertension. So he actually looked at quite a few patients with ischemic optic neuropathy, did 24-hour blood pressure monitoring, and found that the normal diurnal variation of the blood pressure is such that the trough happens early in the morning. And in patients who have lost autoregulation, this drop is much higher than normal people. Plus, an interesting factor is if you look at the diurnal variation of the intraocular pressure, it peaks early in the morning. So you have a double whammy. You have raised intraocular pressure and low systemic blood pressure happening at the same time, which probably tips these patients over to ischemia. Yes?
Is it therefore more common for these people to complain of the onset early in the morning?
Exactly. And Dr. Hare, in his study of, I think, 600 patients of ischemic optic neuropathy over his lifetime, has reported that 73% report loss of vision early in the morning. So it's either I woke up in the morning and I found that my vision was decreased, or I went to put on my makeup and then I couldn't see out of that eye. So the first opportunity that they get to really test vision uniocularly is when they notice it. Others have disputed it, but I will stick to what he said. There is no definite evidence that all of these directly contribute to ischemic optic neuropathy. A recent study by Lee et al., who looked at Medicare database and looked at patients who had a diagnosis of diabetes and ischemic optic neuropathy, showed that having diabetes increased your risk of ischemic optic neuropathy by 43%. Another recent study did the same thing, looked at a couple of tens of thousands of patients in a database, looked at sleep apnea, looked at ischemic optic neuropathy, and found that there was a greater risk. Again, these are some risk factors which, when I see ischemic optic neuropathy, I commonly ask and have the primary care follow through with it closely. The risk factor that is most important for an ophthalmologist and probably for a neurologist as well is the local risk factor. Patients who have ischemic optic neuropathy are more commonly Caucasians. They are more commonly found to have what's called as a disc at risk. So if you look at these two discs, they look crowded compared to the disc which I showed you in an earlier photograph. There's virtually no cup in this disc and probably a small 0.1 cup. If you look at the fellow eye of a patient with ischemic optic neuropathy, this is what you're most likely to see. And there are different mechanisms proposed as to why somebody with this kind of a disc with the other risk factors would end up having ischemic optic neuropathy. The two major hypotheses is that there is chronic mechanical obstruction to exoplasmic flow, which, when you add ischemia to it, would just produce a cascading mechanism of death of axons. And this produces what's called as a compartment syndrome. You have a small crowded disc with 1.2 million axons traveling through it. If there is ischemia, it leads to edema, more pressure on the laminar structures, more ischemia and more edema. The cycle goes on till a balance is achieved. So if you carefully ask patients about the course of ischemic optic neuropathy, they usually describe a stepwise and often a sectoral loss of vision. So I had this one patient who came and say, every morning I would wake up and I would lose 1 pi of my visual field. She would describe it exactly as 1 pi, almost a clock hour fashion. And as I said, it increases the risks of ischemic optic neuropathy in Caucasians compared to, say, blacks, Hispanics, or Indians who have a much bigger optic nerves and more liberal cups. Ischemic optic neuropathy has also been seen to be increased in optic nerve head drusen and is the most dreaded complication of papilledema. That is the common cause of acute loss of vision in papilledema. And this is the one that usually tips me over to surgical management in these patients. Other risk factors include raised intraocular pressure that I had talked about earlier. Studies have shown that if you have had any kind of intraocular surgery, especially cataract surgery, the risk of having ischemic optic neuropathy increases in the first year, and nobody knows why. So if I have a patient with ischemic optic neuropathy and who's got cataract in the fellow eye, I usually inform them that there is a theoretical increase in the risk of ischemic optic neuropathy. Several papers have listed migraine as one of the causes of ischemic optic neuropathy. These are complicated migraines, and it is believed to be altered autoregulation and vasospasm. The first paper that came out for migraine-related ischemic optic neuropathy was in Lancet, I think in '85. And since then, a number of case reports have shown that this may be so. And Dr. Harry agrees with this and says, again, it proves that local factors are much more important over here. So it produces a local vasospasm in a patient that's already at risk for developing ischemia, and something just tips it over. Medications. The most talked about medication recently is interferon alpha, which is used in different kinds of malignancies, especially hairy cell leukemias, melanomas, renal cell carcinomas. And they have found an increased risk of ischemic optic neuropathy by using this medication. There are about 36 case reports, including positive rechallenges. Now, I scoured the literature for interferon beta and could not find anything other than a couple of cases of retinopathy. So nobody knows, again, why this happens, but it's believed to be either or of hypotension induced by interferon administration or immune complex deposition related to interferon alpha. The other interesting medication is erectile dysfunction medications, the sildenafil and tadalafil. This was much hyped about about 3 or 4 years ago, but since then about, I think, close to 50 million prescriptions have been written for these medications, and fewer than 100 reported cases of ischemic optic neuropathies have been shown. So Giuliano et al., who looked at this in great detail, have proposed that the incidence of ischemic optic neuropathy in this population is not much more than the regular population. Amiodarone was also implicated at some point of time in ischemic optic neuropathy, and again, there is nothing definite. So if I have a patient with ischemic optic neuropathy, I ask them about these medications. I then write a note to the primary care physician saying that there is an association, but I don't feel strongly about it, and just leave it at that. So how do these people present? So ischemic optic neuropathy most of the time presents acutely as a painless loss of vision. In about 12% of cases, there is some ocular discomfort, but you typically do not see the eye pain which aggravates with eye movements that you would see in optic neuritis. Here you have a patient with florid disc edema. You can see the extent of the edema in this ring sign around the optic nerve. So that's the extent of the edema in this patient. Much debate about what kind of edema it is. Some people have suggested that ischemic optic neuropathy typically produces a pallid disc edema, but then it takes at least a couple of weeks for pallor to develop. So I would just stick to saying they have disc edema. A curious factor noted in these patients is telangiectatic vessels at the watershed regions, and this is believed to be a luxury perfusion of the optic disc. We again have the luxury of performing fluorescein angiogram as and when needed in these patients, and typically the optic disc should have this color where there should be some staining of the disc. This part of the disc and maybe this part of the disc is not taking up fluorescein as is common, and so this is the region of hypoperfusion with some hemorrhage seen over the disc. and this would correspond to the common visual field defect of altitudinal field defect in these patients. Natural history was again studied by Dr. Here based on his lifetime of close to 400-500 patients with ischemic optic neuropathy. And he was the first to describe that these patients typically present the first thing in the morning when they see that their vision is down. Lack of pain tells us that they may not be able to pinpoint it to accuracy, but they will be pretty close to where they are. At initial presentation, half of the patients have a visual acuity of 20/30 or better, with about a third of these being 20/30 or better. So visual acuity drop is not necessary in patients with ischemic optic neuropathy. However, visual fields are damaged in almost all these patients at presentation. When he studied these patients for numerous years with a median of, I think it was close to 3.8 years, he found that by about 6 months, 40% of the eyes with a visual acuity of 20/70 or better had improved. And if he includes the entire cohort of his patients, this number drops down to about 22 to 23%. So roughly a third to a half, fourth to a third of these patients show an improvement, spontaneous improvement of visual acuity by about 6 months. And this is important to know because of the new experimental treatments that are now being tried, in clinical trials to see if they are really efficacious or not. One has to keep this number in consideration. He also found that about a fourth of all eyes with moderate to severe visual field defect showed improvement up to 6 months. Beyond 6 months, there is virtually no change. So it appears to stabilize after 6 months. The ischemic optic neuropathy has also been looked at from the point of view of systemic vasculopathic risk factors for cerebrovascular or cardiovascular events. And in one of his papers, he suggested that there is an increased risk for subsequent events, especially TIAs or strokes or myocardial infarction. Again, controversy about this topic. Several others have not shown any such increased risks, but usually we end up managing people with cardiovascular risk factors anyway. Other studies have looked at white matter lesions in the brain with patients with this disease and found that there may be slightly increased numbers. Sohan Here also looked at the risk of recurrence over the following 5 years in the same eye as well as in the fellow eye, and he found that the recurrence in the same eye was about 3 to 6 years, whereas fellow eyes was close to about 15 to 25%. So if a patient has ischemic optic neuropathy, I usually tell them that the chances of fellow eye involvement is about a fourth in about 5 years. What is the natural progression of this disease once it involves the eye? Sohan Here again believes that there is a condition called incipient ischemic optic neuropathy. And I saw a patient with this particular condition recently in my clinic, where they present with isolated disc edema without any visual field defects. Now, how did he study these patients? He studied these in the fellow eyes of already established ischemic optic neuropathies. He had them follow up at periodic intervals and noted that similar things happened in the fellow eye. When he followed these eyes over a period of 5 to 6 years, he found that 50% or half of these patients spontaneously resolved without any sequelae. In 25% of these patients, there was a recurrence of disc edema, and in another 25%, this disc progressed to ischemic optic neuropathy. When it does progress to ischemic optic neuropathy, it presents as acute AION with visual field deficits. Pallor develops in about 2 to 3 weeks, and disc edema typically resolves in 4 to 6 weeks. If it does not resolve in 4 to 6 weeks, it's time for imaging and lumbar puncture, because then you're talking about other causes, especially compressive causes, infiltrative causes. Here is a patient that I recently saw. This was a patient who came for a 6-week follow-up to my clinic. Dr. Haq was there with me that day. He had disc edema in the right eye and had incipient AION without any visual complaints. Unfortunately, there was nothing much I could do for him other than put him on an aspirin. The eye that was involved was the left eye, And he had initially presented with acute loss of vision. His visual acuity was about count fingers, and he had improved to about 20/60 in this eye at follow-up. You can see the development of disc pallor in a segmental sectoral fashion, and when you look at the nerve fiber layer in this patient, you can again see the sectoral drop of the nerve fiber layer axon. So this is about 6 to 8 weeks down the road. So while the inferior and the temporal quadrants of the optic nerve show normal nerve fiber layer, the superior and the temporal parts show a significant drop, and this was borne out by visual fields which showed an inferior altitudinal field effect. Treatment. So far, we didn't have any treatment for these patients, and the standard answer was, sorry, you've got a 20% chance of this happening in the other eye, nothing I can do about this eye. Till Sohan Here published his lifetime work of 613 patients with AION in 2008. He saw these patients over a course of 27 years. He included patients who were seen within 2 weeks of onset and with visual acuity of 20/70 or worse. This is not a randomized clinical trial, but can come as close to a randomized trial in this group of patients as you can possibly think about. He offered these patients who came within 2 weeks and had disc edema the option of treatment with steroids. He started them on 80 milligrams of steroids, treated them in a tapering dose for close to 2 to 3 weeks, and then followed them up serially. He found that patients who were treated had a 70% improvement in visual acuity and a 40% improvement in visual fields in follow-up compared to those who did not get treated. So his hypothesis was, if you treat these patients in the acute stage when there is disc edema and possibly compartment syndrome, you're trying to decrease the amount of edema and hence subsequent visual loss. So again, another controversial subject. It was so controversial that none of the American journals actually agreed to publish this paper, and it eventually got published in the Graves archives in Germany. But people have come around, and Dr. Corbett supported this paper and essentially proposes that if you see a patient with ischemic optic neuropathy with disc edema, offer steroids. It's up to the patient whether they want to get treated or not. And if it were my eye, I would opt treatment with steroids.
Well, what about lowering intraocular pressure to improve perfusion?
Has not been shown to help. In fact, if anything, it's actually shown to worsen it, unless you have florid glaucoma. The reason is it's believed to be a problem with autoregulation around the optic nerve head. So if you decrease it, it just doesn't do it. The process has already started. They have tried using medications like brimonidine in the fellow eye. Brimonidine is a glaucoma medication as well as a so-called neuroprotective agent, and they did not find any difference. Other problem with using glaucoma medications is the categories of medications that we have are either beta blockers or they are prostaglandin agonists, and both of those have been found to alter the autoregulation. So nobody uses those medications anymore. Other treatments that have been tried and discarded include surgical decompression. Now, this was a theory that actually came out of the University of Kentucky by, I think, Dr. Baker. He was a proponent of optic nerve sheath fenestration and decompression in ischemic optic neuropathy. It was an NIH trial called the Ischemic Optic Neuropathy Decompression Trial, and it showed that there was no beneficial effect on this condition. If anything, 24% of the treated eyes deteriorated. Aspirin, no improvement in visual outcome in the involved eye, conflicting results on prevention of fellow eye ischemic optic neuropathy, but nobody is going to blame you for starting these patients on aspirin because as it is, they already have the risk factors for cardiovascular disease. Other forms of steroids have been tried, including intravitreal injections of triamcinolone acetonide, which has not been found to be beneficial. Intravitreal bevacizumab, which is Avastin, and is now considered to be the panache for all ocular diseases. You have ophthalmologists injecting it for virtually everything. Unfortunately, in this case, it has not been found to be of any benefit. A promising medication is intravitreal erythropoietin, which was used in a small study of 31 patients, and it showed improved visual outcome in pretty much all of these patients. This study is now out in trials. It's believed that erythropoietin has some kind of a neuroprotective effect. But again, not many people are using this. Clinical trial that is ongoing is the use of short interfering RNAs. These are believed again to be neuroprotective in nature. These RNA molecules, they interrupt the process of apoptosis by blocking caspase-2 expression and delaying retinal ganglion cell apoptosis. UK is also a part of this clinical trial, which is called the QUARK trial, in which you're taking patients with acute ischemic optic neuropathy and attempting to give them intravitreal siRNA. We still don't know the results yet. The molecule has been used in rodent models of optic nerve disease, especially optic nerve transection, and has been found to be beneficial. So currently, the treatment of this disease is reduction of the risk factors, the cardiovascular risk factors, aggressively with help of the primary care physician. Start them on aspirin for coexisting vasculopathic risk factors. Offer them steroids. If they want to take it, fine. If they don't want to take it, fine. And manage antihypertensive medications. Dr. Harry is very particular about this particular aspect of management. He's seen that the loss of vision occurs early in the morning, and so he proposes that if your patient is hypertensive, have them take the blood pressure medication in the morning rather than late in the evening. And that mitigates the diurnal drop of blood pressure early in the morning. Another setting in which ischemic optic neuropathy happens is renal dialysis because of the significant fluctuations of blood pressure, and often you have renal patients present with ischemic optic neuropathy, especially the younger patients. Moving on to posterior ischemic optic neuropathy. Posterior ischemic optic neuropathy is so rare that Dr. Corbett says don't even think about it. If you think it is PION, think again. It's likely to be something else. In his lifetime, remember, he's seen about 600 to 800 cases of ischemic optic neuropathy of the anterior variety. Dr. Harry has seen 53 of the posterior variety. And he describes this in 3 different settings. Non-arteritic, which is similar to the non-arteritic anterior ischemic optic neuropathy. The arteritic variety, which is from giant cell arteritis. And the surgical variety, which is post-operative loss of vision. These are the 3 clinical settings in which you're likely to see. Remember, the non-arteritic variety was 7 times more common in the anterior ischemic optic neuropathy. Here it is almost 1 to 3. So anytime I think of posterior ischemic optic neuropathy, it is almost always synonymous with GCA if the patient is older than 60 years. So I almost end up getting biopsies in all of these patients. Most common site of injury is in the post-operative ischemic optic neuropathy, which has now come to the fore as a medical legal issue, is in the setting of general anesthesia with surgeries where the patient is lying prone, spinal surgeries, or in surgeries where there is significant hemodynamic compromise, such as cardiac surgeries or aortic surgeries. In these cases, usually the posterior ischemic optic neuropathy is bilateral, and you have a patient that's gone in for an elective surgery, wakes up blind. In 1999, recognizing this condition, the American Society of Anesthesiologists established a post-operative visual loss registry. The reason this was done was because there were just a few smattering of case reports, and although every anesthesiologist and every cardiac surgeon had probably seen this case more frequently than that. So it was believed that this was underreported. So to truly check this out, they established this registry, which was voluntary, and they had to report visual loss within 7 days of a non-ocular surgery, and it was designed to identify risk factors and to prevent this devastating complication. So when they analyzed the results of this registry a couple of years ago, they found that 73% of cases were related to spine surgery. Two factors, lying prone and the artificial drop of blood pressure to achieve hemostasis. Mean age, 50 years, 72% were men, not sure why that would be so. Very rare in children, but occurs. For it to happen in children, the drop in blood pressure has to be enormous. 64% of these patients were found to be ASA status 1 or 2 and had no vascular risk factors. So these could be truly ascribed to the complications resulting from surgery. So you can see the pie chart over here. Majority was spine surgeries. Next common was cardiac, major vascular. If you combine the two, it's cardiac and major vascular. Orthopedics, especially those that come in with acute trauma, fractures of the major bones, are the other major groups. Most patients were aware of visual loss on waking up, except the ones that underwent a cardiac surgery because they were put in coma in the immediate post-operative phase. The true delay is usually secondary to cardiac surgery with severe blood loss, where the blood pressure is consistently low for a long period of time in the ICU. So anytime you get called for a patient in the cardiac ICU with acute loss of vision, ask about blood pressure. Inevitably, you will see that the blood pressure was in the 80s and the 70s for somebody who was used to tolerating 120s or 130s. CT or MRI imaging was not helpful except to rule out bilateral occipital strokes or pituitary apoplexy. So they looked at the different risk factors and found that hypertension, either relative or absolute, was the single most important factor. Add to it anemia, blood loss, hemodilution, hypoxia, large volume of crystalloid use. You get the picture. It is the same thing. It is lack of oxygen to the most distal part of the optic nerve. So hypotension coupled with anemia, blood loss, and in acute trauma, when you load them with crystalloids, that's when this happens. Other common causes: positioning of the patient, especially if the head position is above or below the heart. Increased venous pressure, increased intraocular pressure, such as somebody accidentally pressing on the optic globe during the surgery. And the anesthetic duration during these major surgical procedures is also a risk factor. The obvious concerns: combined low hematocrit and hypertension, spinal cardiac surgeries, loss of 1 liter or more of blood, 6 hours or more of anesthesia, and prolonged anesthesia found in a majority of these patients. So how common is it? Extremely rare. Mayo Clinic looked at 500,000 cases of spinal surgeries, orthopedic trauma surgeries, and found that this was 8 in 10,000. University of Chicago, of the 60,000 cases, they found 1. Mayo Clinic, 28,000 odd patient, 17 patients had ischemic optic neuropathy. So all major centers report a minuscule number of ischemic optic neuropathy. However, in the appropriate setting, one should be aware of this. And we have got called on a few patients in the ICU post-cardiac surgery that have had this. Steroid treatment of posterior ischemic optic neuropathy. If it is in the post-operative setting, there's not much use for it. If it is due to giant cell arthritis, then obviously steroid has a role to play in it. However, Dr. Harry again found that if it was due to hypotensive ischemia, if you use high-dose steroids in the short term, it improves visual acuity and field, probably by artificially raising the blood pressure up. Again, nobody knows. You just offer it to the patient and see if they are willing to take it. So to conclude, the intraocular optic nerve forms a transition zone and is susceptible to damage. The non-arthritic anterior-ischemic optic neuropathy results from small vessel ischemia due to local and systemic risk factors. About 40% of patients show spontaneous improvement over time. So all treatment modalities or experimental treatment modalities have to compete with this number. 15 to 20% risk of fellow eye involvement in the next few years. And oral steroids in the acute phase of the disease was found to be helpful in improving visual outcome. So I'll conclude my talk with that. And before I open it up for questions, let me briefly talk about a new trial that we're going to start here, the idiopathic intracranial hypertension treatment trial. This is a multi-center double-blind randomized placebo-controlled study of weight reduction and or low sodium plus acetazolamide versus diet in patients with IIH. So in this study, we are including patients with IIH who are newly diagnosed, naive to treatment, to look at two different things. What is the pathogenesis of this condition and what is the effect of treatment? So patients will be randomized to two groups. Both groups will be treated by weight loss. One group will be treated with acetazolamide and the second group with placebo. And then we will follow visual fields in these patients to see if there is any change. The reason being there has been no study which has ever proven if Diamox is helpful or not in patients with IIH. We will also do lumbar puncture in these patients and draw bloods to look at pathogenesis of this condition. There'll be some genetic studies looking at common polymorphism seen in these patients, especially those that relate to vitamin A metabolism, because that is now seen to be the implicating factor in development of this disease. So I just wanted to introduce the study to you. We will be a site over here. It's in the IRB stage right now. So if you get any cases with papilledema with normal CT head suggestive of IH, please send those patients to me and we can enroll them into the study. It's a study that is... So this is an NIH funded study. And we see a lot of these here. So I'm open to any questions, please.
So I just want to get back to the treatment of AION. It seems to me that there's a parallel here with the brain edema we see, say, with stroke or with tumor. Why hasn't, and maybe they haven't, I'm just unaware of it, why hasn't someone tried osmotic diuresis like mannitol or albumin in these patients to see if that improves their... Because what Hayra believes is that this is edema and compression against this collagenous structure of the lamina cribosa, right? So you want to reduce the edema. Has anybody tried that?
Well, somebody has tried something more radical than that. They've done decompression. They've done decompression and they've gone in through the eye and done what's called as a radial neurotomy, where they have made nicks into the optic nerve, you know, going intraocularly after doing a vitrectomy and found no benefit from that. Nobody has tried osmotic diuretics, probably because Sohan Hare actually believes that the problem is more of autoregulation than a mechanical one. So if you're going to use osmotic diuresis, you may actually drop the blood pressure in these patients. And that's why I guess nobody's ever tried it. I mean, nobody's tried Diamox in these patients, mannitol in these patients. They've not tried anything that would do anything to lower the blood pressure. Yes? Okay, so the question is, what is the typical time from the patient waking up in the morning to being in the chair in front of me? Very variable. It depends on the patient. Usually, a more observant patient will rush to the ER within a couple of hours. The less observant patient can come anywhere from a week down the road to 2 weeks down the road. Sometimes they come when the disc is atrophic. They just notice it because they happen to rub the other eye. Very variable. Yes, Heather. Yes, the study was in patients who presented within 2 weeks of onset. He goes on to propose that if you see disc edema, that's the setting in which you give steroids to these patients. So what I do is, if I see disc edema, I offer steroids and offer it till the time the disc edema resolves. Yes?
Curious,
It's possible. Again, the controversy is on the pathogenesis of this condition, which plays the dominant role. The theory is that autoregulation is the one that plays the dominant role, and the edema plays the secondary role. The controversy is also on how these patients progress. Is there a steady decrease? Is there no decrease? Or do the patients remain the same? And unfortunately, because of the low numbers and because of the inaccurate presentation of these patients, they present anywhere from 1 day to 2 weeks down the road. Nobody knows what happens in the initial periods. Even if we were to try Diamox, what is the optimal period for trying it? And what if we actually worsen the condition by changing the hemodynamics of it? Diamox would be useful because it would decrease the intraocular pressure. It's a good glaucoma medication in the acute stages. Plus, it is helpful in decreasing the local compartment syndrome. It's a thought I have to ask Dr. Corbett, I guess. But
what animal model most faithfully recapitulates AION? And why don't you just try it in that?
Unfortunately, none. So till about 3 years ago, we didn't have an animal model. What they did was they would use light or laser to induce ischemic optic neuropathy in rodents, and now they have done it in primates as well. So now they're trying all of these medications in those models. But there is no true equivalent of ischemic optic neuropathy in an animal model.
I have another question.
Yes.
On your study.
Yes.
And my concerns are in the time. Do you have any instructions for us in a holding pattern until we could get in touch with you? I'm concerned about perhaps not doing them in a timely sequence of how we should approach these. Because it's my understanding you want to take the patient before anything has been done. I think we appear to be dealing with pseudotumor. And so if we believe that to be the clinical diagnosis, but what, I know we should contact you, but you might not be readily available at that time. Is there something we should do, should not do, or should we proceed on with our treatment and pull them out of the study based upon our concerns about the possibility of vision loss?
Absolutely. Once the study starts, I will actually devote 1/2 of a day just for papilledema and ischemic optic and IIH patients related to the study. So I will usually, and even now, I usually end up seeing any referrals that I get for IIH within a week as a overbook. If these patients have already had a lumbar puncture done, that's fine. We will still enroll them into the study and then randomize them to see where they fit in. The only criteria, the only exclusion, right now we are only taking the adult patients into the study, and the only exclusion criteria that is of significance is if they've been treated on Diamox for more than 7 days.
So even if they had been, define adult.
18 and up. And I asked why that was so. The reason given was because of the consent required in the pediatric population. These people are given the option of weight reduction through the New York Obesity Research Center. And it seems that there is some problem getting the IRB to get it approved for pediatric population. Secondly, even if pediatric population had to be included, they would probably have limited it to post-pubertal patients who resemble the adult IIH rather than the prepubertal ones.
I hesitate to suggest this, but also being someone who likes to recruit patients in clinical studies, what about if I found someone in the clinic who I thought had pseudotumor? I'll just go ahead and call you on UK and B, and you can decide and do what you want.
Absolutely. Absolutely.
Fastest and easiest.
Yes. Absolutely.
But even if they had been treated with Diamox
That is, less than 7 days is not an exclusion. Yes. And once we get the study approved, this is more of an introduction. I will be emailing and sending a letter, And then again, any patient that needs to be seen by me, I will be ready to see them. Usually I see them within a week once they are, emergencies. Yes, it.
Migraine is a risk factor for ION. Is there a difference between migraine with aura or migraine without aura? And what do you think about using short-term or short-acting beta blockers like Inderal for migraine for short access, especially given the aura?
Beta blocker is contraindicated in patients with AION and migraine. Don't use them.
Is there a difference between the migraine with aura and without aura?
This is so rare that I think there are about 10 or 12 reported patients split equally, and they just call it complicated because it presents with retinal features. So they have acute loss of vision which just does not improve. So some of these patients that have labeled as persistent migraine aura, I don't know if they have a subclinical ischemia. Yes.
When you decide to give the corticoid treatment, for how long the patient has to take the treatment, and if there, when you decide to stop the corticoid, or if the second one is if there is any blood work that it, like in temporal arteritis, that they check the ESR.
Yes.
In order to.
The question was how long do we continue steroids and what tests do we do? Ischemic optic neuropathy, generally you do not do any tests except ESR C-reactive protein in the appropriate patient. That is, patient above the age of 60 with headaches. Steroids is offered for 2 weeks or till resolution of disc edema. So these patients, I usually follow them every 2 weeks till the disc edema resolves, and then I follow them 6 monthly for a couple of times after that.